So I have added this picture. Now you can see this vitamin B12 is very similar to, it has got cobalt. So cobalt micronutrient in our body required in the form of vitamin B12 only. This is a very important thing you can understand. Cobalt is actually required in the form of cobalamin only. Cobalamin. So we require two types of cobalamin for our body. Actually, our body utilizes two types of cobalamin. One is methylcobalamin and second is adenosylcobalamin. So two types of cobalamin our body required. And our body has only two enzymes. Only two vitamin B12 containing enzyme. Two vitamin B12 containing enzyme. One is, we will talk of, one is, both starts from M. One is methionine synthase. Methionine synthase. Other is, you already know, methyl malonyl coenzyme A mutase. So methionine synthase and methyl malonyl coenzyme A mutase. So methionine synthase require this, methionine for methyl, you can remember, and this methyl malonyl coenzyme A, MMA, MMC, you can see methyl malonyl coenzyme A require synthase, require mutase require this adenosylcobalamin. Only two enzymes and two types of vitamin B12. And this is vitamin B12, similar in structure to our, because see, I have been telling you, though it is not asked in exam, but solid concept and memory. The structure is very vital for that. And that is why I keep focusing on structure. Forget about these two things. I will tell you this. So let me see, the cobalt here is the cobalt, and then you can see NH2 group here. And this is what is called, this is called pyrrole structure. This is also pyrrole structure. And this is also pyrrole structure. Same way we have seen hemoglobin. This cobalamin, vitamin B12 is similar structure to hemoglobin. So you can see at one place this is directly bound, and at other places it is bound by this methylene bridge. This is very similar to your heme. This is very similar to heme. Now the same way heme binds with 6, one oxygen, other with this protein. Here it binds with the 6 coordination, but this 5th coordination group, it has got its own organic compound. You can say R group. This organic compound binds here, and then one additional, this will bind either with methyl. Based on that, it becomes methylcobalamin, or it can bind adenosyl. So methyl adenosyl, this methylcobalamin is required for the enzyme called methionine synthase, and then adenosylcobalamin is required for enzyme called methyl malonyl coenzyme A mutase. So only two enzymes in our body, only two enzymes we have which require vitamin B12. Remember, this is a very important concept. Only two enzymes requires. And this with methionine synthase, homocystinuria is related. This disorder related, homocystinuria. Okay. And with this, with MMN, neuropathy. And this is the enzyme of propionic acid pathway. So this is why this understanding of vitamin B12 helps. You can see here. So this here you can see this group. This I call this R group. You can see big molecule. It is bound to one of the pyrrole ring, and it is bound. It makes the 5th coordination bond, and this can be either methyl. Based on methyl, it becomes methylcobalamin. If it is adenosyl, it becomes adenosylcobalamin. This is actually our part of enzyme. This is part of methionine synthase. I am repeating it. This is part of MMM. But dietary vitamin cobalamin, these are dietary form. When we take in diet has got this cyano or OH, hydroxymethylcobalamin or cyanocobalamin. And this hydroxycobalamin will be modified into methylcobalamin, adenosylcobalamin in our body. Because our body require methyl or adenosyl. Remember this very important concept about this. Now, let's see about digestion and actually absorption. Digestion will not happen, absorption. I told you this, remember this table. You can see R factor protects from acid. Okay, from actually pepsin. R factor actually from protect it's from its acid and pepsin, stomach environment. So this R factor is released from salivary gland. And then in stomach, this intrinsic factor is released. So this will be destroyed and then it will, this parietal intrinsic factor will bind now on what? It will bind to this vitamin B12 in intestine actually. This is secreted here in stomach. It will bind in intestine with this. Yeah. And intrinsic factor, R12 factor will actually be, it is a complex which will be absorbed. It is the complex intrinsic factor B12 is the complex which will bind to this receptor and it will be absorbed. And then after absorption, this is the protein that will, so let's see this first image. You can see from salivary gland, so this R factor will go here. This is salivary gland, you can see mouth is here. So this R factor, it will bind this vitamin B12 here. So vitamin B12, we can see it will be broken down. It is already bound to the protein. It will be broken down in intestine and actually R factor protects it in stomach. And then when it goes from this stomach, intrinsic factor is also released from here. And when it goes to intestine, now you can see R factor is digested in intestine. And R factor after released, R factor, this vitamin B12 will binds with intrinsic factor. Okay, so vitamin B12 intrinsic factor complex now will be absorbed from the terminal ileum through the receptor. The receptor is, this is the receptor. This is vitamin B12 IR receptor, intrinsic factor receptor. This is basically intrinsic factor receptor. It will bind intrinsic factor and vitamin B12 will be absorbed inside the enterocyte, ileum. And then what will happen? This will be segregated. This vitamin B12 now will come out of the very important, this transporter, MDR transporter. And this MDR transporter now actually bind with the transcobalamin. The transcobalamin is also released from enterocyte also. And now you can see this after binding transcobalamin, it will reach various tissues, especially liver, you can see. It will reach liver and liver will absorb this vitamin B12. So this is the actually absorption of vitamin B12. Vitamin B12 absorption is very important because it requires multiple steps. Many proteins are involved in vitamin B12 absorption. First is R factor haptocorrin because it binds corrin. That is why haptocorrin vitamin B12 ring is corrin ring. So haptocorrin, cobalt containing ring, cobalt ring, corrin. So you can remember that is where name came from, corrin, cobalt ring. So cobalt containing ring, that it is also called transcobalamin 1. Now it will reach, it protects vitamin B12 from gastric acid and other environment. Now this R factor will reach intestine. So R factor will dissociate and intrinsic factor binds, and intrinsic factor B12 complex will bind to the receptor and receptor will absorb. After absorbing receptor, this is the, remember this type of protein we will talk later also. MDR, multi-drug resistant protein. We will talk in bilirubin metabolism also, MDR. So MDR protein will excrete. This is ATP binding cassette protein. Remember, this is ATP binding cassette protein. This is a very one group of protein. It will utilize ATP. It will utilize ATP and its function, this MDR protein function is always excretion from the cell. It will utilize ATP. So active excretion, it will throw out of the cell. So this is the function of MDR protein, excretion from the cell. And then it will reach blood. In blood, it will bind transcobalamin. And transcobalamin bond, vitamin B12 will be actually absorbed by transcobalamin receptor. It is present also in liver and other tissue as well. So this is the actually absorption and transport, and again reabsorption from other tissue. This is the whole process. So I will tell you here, after reabsorption, after it is reabsorbed here through this receptor, transcobalamin receptor, CD320, it is CD320, it is transcobalamin receptor. What will happen? It will enter cell, inside cell. So vitamin B12 will be dissociated, and this vitamin B12 actually form complex with two types of enzymes. Forget about all this. There are many proteins involved in involved in complexing this vitamin to the enzyme. So you can see this vitamin B12 will be converted into adenyl, adenosyl. As you know, adenine group, when it attached to the 6 group, it is called adenosyl. So it will form the part of MMM. And MMM is present inside mitochondria, not in cytosol. And this is part of propionic acid pathway. Now, second enzyme is methionine synthase. So this methylcobalamin will form part of methionine synthase. Only two enzymes is present. One is mitochondrial enzyme, which is part of propionic acid pathway. This is this. And one is cytosolic enzyme, which is called methionine synthase. And then this methionine synthase, if there is deficiency in methionine synthase or vitamin B12, so this can cause homocystinuria because of inactivity of this. You can see homocystinuria is associated with methionine synthase. And this methylmalonic aciduria is associated with this. And methylmalonic aciduria is associated with neuropathy. Neuropathy. So one enzyme is associated with neuropathy, other enzyme is associated with homocystinuria. This is a very important. Once you know two enzymes, you start understanding vitamin B12. So homocystinuria is because of this methionine synthase activity deficiency, and neuropathy is because of this. Methylmalonic acid will cause neuropathy. And then I will tell you more later. And this homocystinuria plus this megaloblastic anemia is also associated with this enzyme. Methionine synthase, homocystinuria, and then megaloblastic anemia with methionine synthase. And then neuropathy and methylmalonic aciduria is MN is associated with this. I will rather draw a picture so that you will remember. So this B12 enter, and B12 actually either will be part of methionine synthase, MS, or it will be part of inside mitochondria. It will be part of what? It will be part of methylmalonyl coenzyme A mutase, which is part of propionic acid pathway. Propionic acid pathway. Now this methylmalonyl coenzyme A is actually associated with the path. This is the cause of neuropathy. Neuropathy. And then this is the cause of homocystinuria, and also with megaloblastic anemia. Neuropathy, why does neuropathy happens? Neuropathy happens because of high MMA. It happens because of high methylmalonic acid. So remember, this MMA is associated with 2 MNN, and this is associated with homocysteine. Methionine synthesis is associated with M and S. So remember this 2 and this 2. If you remember, so whole disorders of vitamin B12 you will remember. These are very important. So let's talk about this concept. A 55-year-old man is brought to primary care physician by his wife for increased confusion. he forgets to turn off the stove after cooking. So forgetfulness, confusion, and then frequently misplaces his keys. He fell approximately 1 week ago while walking in the dark. His physical examination is notable for impaired short-term memory. Okay, memory is impaired. Decreased vibration and proprioception. So, which track is involved? Dorsal colon medial lemniscus pathway is affected. This means vibration, proprioception. Patellar hyperreflexia is there. On laboratory testing, he has a macrocytic anemia, reticulocytosis. So anemia is there, and that is also macrocytic anemia. This macrocytic anemia means vitamin B12 deficiency. Okay, two types of, I told you, one vitamin B12 resistant also is there. So don't forget that also. So though it is rare, but it is there because it is involved in orotic aciduria. So this is vitamin B12 deficiency. Low serum vitamin B12 was found. And because of vitamin B12, you can see this patient has neuropathy. This is presentation mainly of neuropathy. So you can see what is the diagnosis. Macrocytic anemia, neuropathy, what is the diagnosis in such patients? High-aged patients. And what is the investigation, additional investigation you will do? So diagnosis, you will see generally it is pernicious anemia. Generally pernicious anemia cause this. So pernicious anemia, because of antibody, parietal cell is destroyed. It is autoimmune disease. So parietal cell is destroyed because of immune antibody. So these are the three features you can see. Megaloblastic anemia, we have seen neuropathy. Neuropathy is associated with function of which enzyme? MMM, methyl malonyl coenzyme amylase. Okay, and megaloblastic anemia is associated with which enzyme? Methionine synthase. Sometimes it is not helpful in vitamin B12 deficiency, but it is very helpful when there is disorder of methionine synthase deficiency in homocystinuria. It is very difficult, very important. In homocystinuria, there will be megaloblastic anemia as well. And then there can be neuropathy or there cannot be. So you can see these three features, M, N, and G. Gastroesophageal atrophy, you can see atrophy, M-A-N. Triad, you can remember like M-A-N, man. So M for megaloblastic anemia, you can use this A for anemia also, A for atrophy. Megaloblastic anemia, atrophy, and neuropathy. These three are the features of this atrophy. You can see this. You can examine the patient's tongue. Tongue will also be atrophy. And you can see this patient, compare this patient's pale hand. You can compare this pale hand with this megaloblastic anemia. So what is the cause of megaloblastic anemia? What causes this megaloblastic anemia? So the cause is folate trap. Folate trap. Remember, cause of megaloblastic anemia, I have told you the enzyme thymidylate synthase. Thymidylate synthase. Don't forget this enzyme. Synthase has folate. And this actually enzyme is required for thymine synthesis. Addition of methyl group to uracil and then thymine synthesis for DNA. And if folate is not there, and this will, in vitamin B12, folate is there, but folate is not utilized. And this is called folate trap. We will tell you how. What is the cause of neuropathy? High methyl, this is MMA, methyl malonic aciduria. Now you can see this propionic, two enzymes are there. One enzymes I told you, one enzymes vitamin B12 containing enzyme, that is adenosyl cobalamin. Containing enzyme is methyl malonyl coenzyme amylase. It is part of propionic acid pathway. So propionate, that is generated either from this amino acids, or it is generated from short chain fatty acids, or it is generated from other phytanic acid. So whatever the phytonic acid, branch chain fatty acid that is present in dairy product. So this three, either of this will produce, any of this will produce propionic acid. Propionic acid will be converted into what? Succinyl coenzyme into two-step process. This is 3 carbon and this is 3 carbon straight chain. This is 4 carbon straight chain in two-step process. The first step requires biotin. Biotin converts this molecule, propionic acid, propionyl coenzyme A, into this type of molecule. This is propionyl coenzyme A. Into, it will add methyl group here. You can see 1, 2, 3, 4, 5. This is called methyl malonyl coenzyme B. Okay. So this is called methyl malonyl. This will add here carboxy group here, because biotin always add carboxyl group. Now this will become methyl group. So this is malonic acid is nothing but you add this malonic. There is difference between malic and malonic. Malic is 4 carbon dicarboxylic acid. Malonic is 3 carbon. So this is malonic acid. Malic, this is malic acid. I will tell you. This is malic acid. OH group is also there. Malic acid. So 4 carbon OH group is there. This is malic acid. This is malonic. Malonic, here methyl group is added. So this is methyl malonic. Now what does this vitamin B12? Does this vitamin B12 change this position of this carboxyl group? It shifts this carboxyl group from here to here. In that, if it changes that group, so what will happen? So this will become this type of group. You can see. So this is a succinic acid. Succinic acid is straight chain. 3 successive. Succinic means successive 4 carbon compound with dicarboxyl. So this is how vitamin B12 converts this into this. So mutase is vitamin B12 helpful in mutation of this molecule. This is how you can remember this two-step process. This pathway is very, very, very important. This pathway is very important. Okay, this pathway is very important. 2 enzymes, remember 2 vitamins plus enzymes. If this vitamin is deficient, what will happen? If this vitamin is deficient, high propionic acid. If this vitamin is deficient, high methyl malonic acid. High methyl malonic acid, MMA. And this will cause neuropathy. Okay, a propionic acid will cause propionic aciduria. This is a different condition. Remember, that is why this is very, very important pathway. 2 pathways are associated. And you can study this yourself. This is the region. MMA is the region for peripheral. Now, second enzyme is methionine synthase. What does this enzyme do? Methionine synthase, actually the methyl group, this methionine synthase will actually transfer this methyl group from this tetrahydrofolate. This methyl tetrahydrofolate is actually, it is an inactive form of methyl tetrahydrofolate. There are many types of methyl tetrahydrofolate. Methyl, you can say formyl, methyl tetrahydrofolate, formyl tetrahydrofolate. There is methylene tetrahydrofolate. These tetrahydrofolate are required in nucleotide synthesis. If you can remember, nucleotide synthesis. And this is the methyl tetrahydrofolate is required here only. And if methyl tetrahydrofolate is not converted into tetrahydrofolate, this tetrahydrofolate cannot convert into this. If it is not converted into this, it will not convert into this, because this is the only enzyme that can activate methyl tetrahydrofolate. And if this is deficient, what will happen? This methyl tetrahydrofolate will rise in body, but it will not be utilized. You got that? It will not be able to utilize. So this is called folate trap. Folate trap. And if this is absent, this will be folate trap. And because of folate trap, megaloblastic anemia. because of this, there will be high homocysteine. So this is why homocystinuria. So I told you, remember, with methionine synthesis, two are related, methionine synthesis. Two disorder is related to methionine synthesis. One is homocystinuria, and other is megaloblastic anemia. And I told you, remember this methyl malonyl coenzyme A mutase, it is associated with neuropathy. And neuropathy is because of high methyl malonic acid. So if you remember this vitamin, you will remember vitamin B12. You can see this methyl will be transferred here, homocysteine. That is why homocysteine is one carbon less than methionine. It will convert into methionine, and then methionine will be reutilized. We will talk about this again. But remember these two function, this disorder related to vitamin B12. Homocystinuria, megaloblastic anemia is related to this, and neuropathy is related to MMN. So Schilling test. Schilling test is a test actually that is done to find out the cause of this neuropathy. This is done to find out the cause of vitamin B12 deficiency. Not neuropathy, sorry. It is done to find out the cause of this vitamin B12 deficiency. So what is done actually? The patient is first prepared, and patient is given actually vitamin B12 given to drink solution of radioactive vitamin B12. Okay, and this is actually not in that much use these days, but it used to be. Sometimes it can be done. It is done. Sometimes very rarely. So radio labeled vitamin B12 given orally, and after 1 hour, intramuscular vitamin B12 is given. I will tell you what is the significance of this intramuscular non-radio labeled vitamin B12. So you will easily understand the function, what is the significance of this radio labeled vitamin B12 from oral route. So what is the significance? It will be absorbed, and you can actually take the urine. After it is absorbed, it will actually excreted in urine, and you take the urine and you measure radioactivity. You measure the vitamin B12 in radioactive vitamin B12. If it is actually quantity is high in urine, so you will understand that actually it is absorbed. Because it is absorbed, that is why it appeared in urine. Otherwise, if it is not absorbed, it would not appear in urine. That is the significance of, you see the absorption, and urine will not have high amount of vitamin B12 radioactive. You can see. So what you do is, you give first test, you do this, give this to here, as I've told you, and then do. If there is normal absorption, there will be more than 10% vitamin B12, radioactive B12 in urine. If it is normal, there will be more than 10%. But in disease condition, there will be less than 10%. So that means it is disease condition. So next you do with the intrinsic factor. If you add intrinsic factor with vitamin B12, and in this condition also you have to give intramuscular vitamin B12. Okay, and if actually intrinsic factor this plus intramuscular vitamin B12, if you give this in next appointment, if the absorption is more than 10%, then you will understand it is because of pernicious anemia. It is because of pernicious anemia. So this is how you can diagnose. This is because of vitamin B12 absorption is because of deficiency of vitamin B12. So this is called Schilling test. And why do we give intramuscular? Because this radioactive vitamin will be can be uptaken by liver. So if this intramuscular vitamin B12 is given, it will bind to the cell of the liver. It will saturate liver, and this radioactive will not be absorbed by this liver. Radioactive will not be absorbed by the liver, and it will be excreted in urine. Radioactive will be excreted in urine. So this is the significance, because intramuscular vitamin B12 is given to saturate all the hepatic receptor. So radio level B12 does not enter hepatocyte. So this is the significance of giving this. Schilling test is very important actually, and you have to understand what is Schilling.